aggressive regimen for resectable disease is in play, and a less aggressive regimen for unresectable disease is in play as well. So I'd like to leave with the notion that sequential therapy is appropriate. There is supportive phase 2 data and phase 3 data that suggests an advantage for TPF regimens. Sequential therapy does remain experimental, but I think it makes sound biologic sense, and I believe it is a reasonable treatment for patients with advanced disease. It is a standard of care in my institution based on our results, just as the standard of care at other institutions might be boluses platinum and once daily fractionated radiation. I think treatment should be brisk with minimal delays between modalities, and treatment breaks and delays reduce local regional control. And when surgery is planned, we want to think of organ preservation, tumor repopulation, and where bulk disease is. And we also need to have patients who are capable of rehabilitation because the therapy is quite aggressive. The long-term and short-term side effects of treatment require considerable attention, and I think combined modality treatment requires careful coordination and communication. In 2006, I think a considerable fraction of patients with advanced disease and without significant morbidities can be cured. I don't think this was the case. I think we've doubled the cure rate in patients who are otherwise healthy compared to what we were doing in the 1980s and the early 1990s. We have sequential chemotherapy, chemoradiotherapy, and postoperative chemoradiotherapy to treat patients with. We need to have a better assessment of risk factors and extent of disease. We do have a better assessment now that we have CT scanning and PET, but I think we need a better assessment of molecular risk factors such as HPV status. We need new agents to improve survival, and we now know that the therapy is long and difficult and requires significant physician care. And as we now have 50 and 60 and 70% survivals, we need to really deal with the toxicity, and now we can begin to ask about new agents with reduced toxicity and look at improved interventions that can, during therapy, to reduce the acute toxicity and improve late function. Drugs like amifostine, palifermin, and other agents to try and reduce mucositis and salivary gland function, functional reduction. IMRT perhaps may be appropriate in this. Thank you.